The following is a production of Texas Lutheran University. For more information, please visit tlu.edu.
I'm Dr. Levens, Chair of Biology Department, and I want to welcome everyone to today's Biology Department seminar. We're very pleased today to have Dr. Jen Olsen as our guest speaker. Dr. Olsen is a graduate of the University of California, Davis, where she earned her undergraduate degree in microbiology. Then she went off to veterinary medical school at Cornell University in New York and graduated in 2009. Since August of 2012, she's been on staff at the Alamo Feline Health Center in San Antonio, a cats-only veterinary clinic. And she's been very gracious to accept our invitation to come today to speak about the disease process, diabetes mellitus, obviously in cats today probably, but has applications to other mammalian systems also. So please speak with Dr. Olsen if you like about veterinary medicine or about diabetes or things along those lines. I'm going to turn it over to Dr. Olsen.
Thank you.
Welcome.
Yes, thank you. So thanks for having me here today. I just had a lovely lunch over at the little student center and just got to speak with some of the mentors and professors that you have here, and they're excellent. So soak them up while you have them, because you might miss school more than you think when you get out. But today we're going to talk about diabetes. It's nice that this is a small enough classroom that if you guys have questions, you feel free to wave or shout or interrupt. I mean, I want it to be something that you guys can be involved in as well. But we're going to talk about diabetes, mostly veterinary things, but to compare to people, because I think it's really interesting to look at what's similar and what's different. So diabetes mellitus, I'll use the shorthand DM. It's really very common. We don't know how common in dogs and cats because lots of them live on the streets and on farms and whatnot. But for animals that come to the vet clinic, maybe 1% of them will have diabetes. In people, the facts on the diabetes website as of last night is that 8.3% of people in the United States have diabetes, 25 million children and adults. So it really is an epidemic. The symptoms, whether you're a dog, a cat, or a person, it's called polyuria and polydipsia, and that gets shortened to PUPD. But really, that's characterized by excessive urination and excessive drinking. And diabetes, at its core, is just high blood sugar, either because you don't have enough insulin or because you're resistant to the insulin your body makes. We're going to come back to all of the diabetes stuff in a second, but I like to be a little bit more personal when I get to talk to people so you know me and it's not as scary to ask questions. So I grew up in Colorado. The big pictures are ones that I took on my cell phone at our place. We live south of Denver, kind of out in the country, have 17 acres and horses, and that's me washing one of the horses. And of course I grew up in Colorado, so everyone skis, and yes, I go skiing. So I missed that a little bit here in Texas, but I can travel home. I can't complain when it's 70 degrees out in February. So then, as he said, then I went to UC Davis and spent 4 years there, graduated with a degree in microbiology. Davis is in Northern California. It's inland from San Francisco, and it's sort of near Napa Valley. It's beautiful and gorgeous. And if you keep going east, you'll get to Lake Tahoe. So it was really nice. You could go to the mountains or to the water. If you ever get a chance, I recommend you go. There's a huge food science program there, and this is the Performing Arts Center, the Mondavi Center, put in by an endowment by Robert and Margaret Mondavi, the wine tycoons out in California. I went to Davis actually on a basketball scholarship. I played basketball all through high school, and that was sort of my ticket to go out of state and travel. They're Division II. I looked you guys up on the internet and saw you guys are D3, so I really love like smaller schools with sports programs like that. It's nice that the emphasis is still on school, but you get to play and travel. So that's always a good ticket to do things if you can. The other thing I did while I was at Davis was study abroad. I spent a summer in Sweden and studied political science, which was a nice way to get all of my non-science credits done. And boy, I would go back to college all over again if I could study abroad again. I mean, when else in your life can you live in another country for 3 months? It was amazing, so if you're not about to graduate, seriously consider studying abroad. Okay, then straight after that I went to Cornell and went to vet school. It's a 4-year program, and you graduate with a DVM, a Doctor of Veterinary Medicine. That's in upstate New York. So there's New York City, there's Ithaca, and then Buffalo and Rochester. Syracuse is the closest big city, but it's really a fairly rural area near the Finger Lakes. There's lots of wineries there too. There's lots of t-shirts that say Ithaca is gorgeous, which is the play on word because there are gorges and waterfalls and all these pretty areas to go hiking. Vet school is a ton of fun because you get to work on every species, whether you want to or not. And so dogs and cats, easily. Horses, cows, chickens, pigs. You go to the zoo, you get to do everything. It was amazing and fun. And then at the end of all of it, you have to take a national board exam about all of the species. But when you graduate, you can pretty much get into whatever niche you want to, which is what most of us end up doing. So after graduation, what I did was an internship. I went to Alameda East in Denver. It's a huge hospital. There's more than 30 veterinarians there. It's open 24 hours. There's all these different specialties. I did what's called a rotating small animal internship. And so every 2 weeks, I would rotate what I was doing. And so I'd spend 2 weeks on medicine, and 2 weeks with oncology, and 2 weeks with dermatology, and do that all year long. Except when you go on overnights, where you're the only doctor in the hospital in the middle of the night, then you do that for a month. And so we would joke that that was vampire hours. So you're there from like 5 p.m. to 9 a.m. And it's good. It was sort of trial by fire. I mean, you have to deal with really sick things and hit by cars and gunshot wounds and you name it, we saw it. So that was a very good experience. These are the 8 other interns I went through it with, and we all kind of saved each other's lives getting through that. The interesting thing about internships as a vet compared to being a human doctor is it's not mandatory. You don't have to do it. You can graduate, go right into practice, you have your license. So they're competitive to get. There's less internships than there are graduates. And so most people do it for the glory, to say, I've done an internship, but it's low pay and long hours, and it takes a hit, especially if you have student loans to pay back and all of that, but to me it was completely worth it. Lots of people do an internship because they want to do a residency. They want to spend even more time in school and start to specialize on, I will be just a veterinary surgeon, and then they'll do another program after that. So I decided I like to work, and it was time to go work. You may have heard of this hospital though, Alameda East. It was famous on Animal Planet. That TV show, Emergency Vets, was shot there, and that's Dr. Fitzgerald, the star of Emergency Vets. And he's a great guy, just as nice in person as on TV. So I'm really lucky to have awesome colleagues. I think across the board, veterinarians are great. So real jobs, then I got some real jobs after my internship in school. I've worked in small animal general practice, emergency and critical care. Beyond my internship, I worked in Boston doing emergency, and now in feline specialty. So I take care of cats and the crazy cat ladies, which is fun too. I like that. But I've lived and worked as a vet in Colorado and Massachusetts and now in Texas. And right now, as they said, I work at Alamo Feline Health Center. It's over in San Antonio. We have 3 veterinarians there. The owner and my boss and mentor is Dr. Norsworthy. He's the author of this feline textbook. So he really knows his stuff. And a lot of people ask, what's your schedule as a vet? It's completely variable. I mean, you can have a job where you work all the time, or you work a week on and off. I work 4.5 days a week, and then we've worked out a deal where I do a lot of research and writing. We're trying to publish papers about things that we see there and patterns we're seeing in our patients. And we're going to write one on diabetes soon. So preparing for this got me more excited for it. Why I became a vet, this is a picture of me and my dad. My dad's a vet, so I grew up around it. I don't think I really had a chance to do anything else because it's so much fun. I just fell in love with it. And then I also liked reading James Herriot books, which I don't know if any of you have heard of him. He was a vet in the 1930s in northern England, in the Yorkshire Dales. And his stories are semi-autobiographical. And he talks a lot about jumping in the truck and going out and doing calvings and foalings and just amazing stories. And I always thought that was what I was going to do. And ironically, now I work just on cats. But you never know where your life will take you. So being a vet is, I think a lot of people have preconceptions about that. It's clearly working with animals. And I think a lot of people say, I want to be a vet because I like working with animals. But there's a lot more to it than that. You have to wear many hats. If you're a general practitioner, which is what I do, you have to do some of everything. I mean, medicine, surgery, you're taking care of neurologic patients and patients with skin disease and patients with cancer and emergency, and you have to do dentistry and extractions and everything too. So it's a lot of different things, which to me is really fun. I think if I did one little niche, I would get bored, but I like that there's so many different hats. And then problem solving. I mean, my patients can't talk to me. I've got to really look and think and try to figure out what's going on. So the other things people don't think about when they say, oh, you're a veterinarian, is I work with people all day, every day. Because like pediatrics, My clients are like the parents. You know, they bring in their little cat, but that's their pseudo child, and so I have to talk to them and coach them and earn their trust. And like I said, my patients can't talk to me, and so there's that extra challenge of, well, are the owners noticing what's going on, or are they oblivious because they have twins, or you know, what's going on in the environment? So working with people is really, really important as a veterinarian, because you have to be able to connect with your clients. You have to be able to connect with the patients and the animals too, and have that bedside manner so you can earn their trust. And if you care about what you do, that's not that hard, but just getting more comfortable with communicating and listening. Sometimes it's life coaching too, I think, a little bit of life coaching. And then being a vet, there's paperwork. It's really important. Medical records are a legal document, so you have to write your records. We write letters to other vets. We write instructions for clients, surgery reports, lab requests. You know, you got to do that and kind of dot your I's, cross your T's. Okay, so this is me growing up, learning from my dad. You can hardly see in this picture, but I was a little baby, and there's my dad, and like 4 black Labradors around me, because we grew up with all the dogs. And that was my first little red kitten that I begged and begged for. And then this was the clinic cat, the cat that lives at the hospital and greets the clients and sits on the front desk. And so we would pose and take pictures with her, and so we're both looking into our ears there. But my dad taught me a lot about what I think it is to be a vet, and he always has a lot of fun at work, and I think I try to do the same. And then this was me as a kid. This was our family dog, Molly, one of the black labs, now clearly much older. She was older than me. They had her before they had me. She developed diabetes. And so when I was a little kid, I had to learn a little bit about it, and I was interested, and I wanted to. I mean, she was like my sister almost. And so I learned how to give her insulin injections and do that. And so for me, diabetes was a pretty personal thing, even when I was very young, taking care of her right up until the end. Okay, so now, transition back to diabetes. Yes, diabetes. So diabetes is high blood sugar either because the pancreas doesn't produce enough insulin, or the body cells don't respond to that insulin, or both. And a lot of my patients have both, which is why cats are tough. So the history of diabetes, we won't talk too much about it. Oh, hold on, what did I hit? And it's 113. Okay. The ancient Egyptians described diabetes, 3,000 years ago. So it's not a new disease. It's been around a long, long time. But it's been more recently that we've been able to work with it. The term diabetes is from the Greek word for siphon, because it's literally siphoning fluids off your body because you have excessive urination. And so unless you drink a lot, you're prone to dehydration. And then there's another type of diabetes called diabetes insipidus, which we won't talk about. But diabetes mellitus, you need that word there too. That's from the Latin for sweetness, because there's a sweet apparent taste to urine or blood, or if there's urine on the floor, it's sticky because of the sweetness, the way soda would be sticky. We'll talk a little bit about that. All right, so then in the fairly recent history of medicine, they figured out in 1889 the pancreas was involved with diabetes, and that if your pancreas didn't make insulin, you might become diabetic. It wasn't until 1921 that they really isolated insulin from the pancreas and started its clinical use. So this is still, I think, in the infancy of managing it, even though it's so common. All right, so diabetes. You have high blood sugar, and what that's going to cause is excessive urination, the polyuria. And this is basic, like high school sort of physics. So if you have too much sugar in your blood, that'll spill into the urine. We won't worry about how that happens, except there's a permeable membrane, which you'll imagine is in the kidney. But anyway, so you have too much sugar in your blood, it spills into your urine, and what that'll do is by osmosis pull more water in. So you pee more because of that sugar in the urine. The drinking more is just compensation, again, so you don't get dehydrated. So if you're diabetic, don't restrict water. I'll have owners that come in and say, oh my God, he's drinking everything in sight. I thought he was going to drink too much, so I picked up the water. And I shudder and go, oh, please don't. He needs to drink the water, otherwise he's going to pee himself into dehydration. Okay, so if your pancreas doesn't produce enough insulin, in people, they use the terms type 1 and type 2 diabetes. So if you have a pancreatic problem as your primary issue, that's type 1 diabetes. If your body cells don't respond to the insulin that is produced, or you have insulin resistance, that's type 2. Now the internet is very blunt about this, and I don't mean to offend anyone, but this is what the internet says about the faces of diabetes. Type 1, you have a genetic problem. Type 2, one of the biggest factors for insulin resistance in people is obesity. So I say that as a fact, and we'll move on if I don't hit the wrong button. Okay. And Halle Berry is truly a type 1 diabetic. I learned that when looking this up. There are other celebrities out there if you want to look. Okay. So why does it happen? If you're type 1 diabetic, you probably have a genetic susceptibility, or your immune system may destroy the insulin-producing cells in the pancreas. And so you just don't have the cells to make the insulin you need. The way you treat that is give insulin. You're insulin dependent if you have type 1 diabetes. Type 2, you have all these factors potentially for insulin resistance. Now these, since I'm not a human doctor, I looked up on the diabetes website, and obesity is a big risk factor. If you do not exercise, that's a risk factor. People over 45 years of age are at higher risk if you have a family history of type 2 diabetes, or if you have high triglycerides or blood pressure. Type 2 is called non-insulin dependent because all you have to do is change some of these things. Now you can't change your family, but you could change exercise and those things, and you can potentially get to a point where you're not diabetic anymore and go into what's called diabetic remission. Now for cats, we don't really say this cat is type 1 or type 2. Most of my patients are probably a mix of the two, but usually I'm managing patients with insulin. So I want you to think of cats as a type 1 diabetic, because that's what we're going to discuss. But what's interesting is I can get some of my patients to the point where they're almost type 2. They're managed without insulin, which is the ultimate goal. Okay, so now we'll talk some about what happens in diabetes. So when I say blood sugar, the particular sugar I mean is blood glucose, which we call BG. You can measure that really easily on a glucometer. You need just a little drop of blood, and you'll see people will prick their finger and use a drop of blood, or there's little lancets so that you can get a small amount of blood. Blood sugar fluctuates all day long, minute to minute to minute. If you just kept measuring it, you would get different values all over the place. And that's normal, that's okay. It'll go up and down through the day. But within a range. It'll get higher and lower, but it shouldn't, it's kind of like the porridge. It shouldn't get too high and it shouldn't get too low. It needs to be just right. And there's all these homeostatic mechanisms to make sure it stays in the normal range. And having a normal blood sugar is basic to life. I mean, it's like you can't have a temperature be too high or too low or you die. Your heart has to keep beating, you have to keep breathing, your blood sugar has to stay in the right range, or it's life-threatening. So, things that will change your blood sugar, this is sort of a column of increase and a column of decrease. Your blood sugar will increase, especially in people, postprandial. That means after you eat. You have a meal, we all just had lunch, our blood sugar is higher now than it was 2 hours ago. Postprandial increase happens in dogs. They'll eat a meal and it'll go up. It's not as significant in cats. They tend to be a little bit more stable and they don't shoot up quite as much after a meal. What is significant in cats that'll increase their blood sugar is stress. They get very stressed out, especially when their owner throws them in a carrier, throws them in the car, drives to the vet, stops too short, the car falls down, the poor cat's on the inside. So stress will really increase a cat's blood sugar. That does not happen as much in people and in dogs. If we took your blood sugar before a stressful exam, it wouldn't be as high as a cat at the vet. It's just the way they're wired. Now, decreases in blood glucose happen primarily in response to insulin. And insulin is naturally made and secreted by the pancreas. If you stop eating for a while, you fast, your blood sugar will go down. It won't get dangerously low because of all those checkpoints and mechanisms, and the liver is the big organ that keeps your blood sugar from getting too low. Okay, hope this isn't too basic. All right, now this chart, starting at the bottom underneath the table, is 0, going up to 350, and these are blood sugar numbers. Normal people in the yellow, non-diabetics, are never less than 50, and they're not going to be too much higher than 150 up there. So you bounce around throughout the day, but you don't get too high or too low. If you're a diabetic, your sugar's high, and then this person is eating and taking insulin, So that should help it come down. But then they eat again, and it goes up again, and then they eat again, and it goes up, and then they take the insulin, and it goes down. And so you see it'll fluctuate throughout the day. And this would be what I would call poorly regulated. Even though they're taking insulin, they're really high for a good portion of the day. You want the diabetic on insulin to be regulated and to look like a non-diabetic. That's sort of the therapeutic goal. Okay, so what happens in a normal person, cat, or dog is that glucose is an energy source for the cells. And glucose will float around in your blood after you've absorbed it from a meal. And with insulin, it'll move into the cells. So that's the normal setup. In diabetics, the glucose can't get into the cells. So in diabetes, glucose is high in the blood and low in the cells. And so if you're a type 1 diabetic, you don't have the insulin. So glucose is in the blood, but it can't get through that receptor. In type 2, you have the insulin and the glucose, but the receptor is blocked by insulin resistance. Now why this is important, or my little analogy for it, because I think it's a little complicated to think about all that at once, is there's an analogy that I made up when I was trying to remember this in vet school that if you think of blood glucose as like temperature in a room, in Texas when it's hot in the summer, and insulin is air conditioning. If it's getting hot, the temperature goes up, because we live in Texas, what'll happen is the air conditioning will kick on. So that's like if your sugar goes up and you have your thermostat set, then the insulin will kick on and keep it back down. So when the temperature gets back to a desirable range, your air conditioning doesn't just keep running, it turns off again. So it's that feedback mechanism. And so that's the same thing with blood sugar, is that it's supposed to be in this range. If it gets too high, insulin keeps it in the normal range. It's a bit more complicated than that, though, because what you eat will affect how high this goes up and how fast it goes up. And so this is a little graph from a study they did in people, where if people ate bread, their numbers go up higher and faster than if they eat bread and almonds. And that's where they talk about glycemic index. And you want a low glycemic index, meaning things don't go up too high or too fast. Because again, this will help keep it more level and avoid those spikes. So what you eat plays a role as well. Now, what's really weird is that even though your blood sugar is high, diabetes is like starvation on a cellular level. Because without the glucose coming in, the cells are starving. They're not getting the food. It's in the blood, but it's not in the cells. And so what the cells do is, if you have a big fat cat like this, the cells think he's in this shape because he's not getting any nutrition or energy. And so the cells say, we need energy, and we have to go through some other pathways. So that's sort of like plan B, survival mode, I'm starving. And most of the sort of survival mechanisms in animals work well. You need it. If you're starving, let's start breaking down some of the resources we have, fat and muscle, get some energy there. But the problem is, if you do that for too long, meaning you're not starving for months and months, or you're diabetic, you'll get buildup of byproducts from those pathways. And the big problem is ketones. If you get enough ketones, those are toxic. And those will start to build up if you're going down sort of the plan B pathways instead of eating like you should. So now we're going to talk about when I have a cat come in, how do I know they're diabetic, or what do we do to figure this out, and then how do we manage them? So diabetes in cats, a lot of times the owners will come in and they'll say, I have to clean the litter box 3 times a day, and I don't know what's going on with him, and he's drinking me out of house and home. So cleaning the litter box a lot means they're peeing a lot. Drinking everything, they can be losing weight. They'll also say he's let himself go. He just doesn't clean anymore, which means they're not grooming, which is because they don't feel good. Or they'll come in and he has dander. He's never had dander before. I mean, it's weird the things that'll lead you to diabetes, but any of those vague things could potentially tip you in this direction. Some of these cats are just lethargic and hiding. He doesn't meet me in the morning when I dry my hair every day. But the real basis of diagnosis is an elevated blood glucose. You get a blood sample, you check the glucose. If it's too high, they're diabetic. Also, that glucose will spill into the urine. You should never have glucose in the urine in a normal animal. So if it's in both places at the same time, they're likely diabetic, especially if you're a person. But in cats, stress complicates things. It makes it very difficult. So cats are these, we call them sympathoadrenal animals, because they get that fight or flight sympathetic response. And that releases catecholamines, and that's why their blood sugar will just shoot up, and it'll be transient. But it'll mimic diabetes. So what do I do when they come in and they're doing this? It's very frustrating. We have one other test, and it's called a fructosamine. What it does is it gives me information on about an average blood sugar for the last week. And what that'll do is if you average things, if they're normal at home, nice low blood sugars, but they spike up in the hospital, mathematically, when you average that, it'll take out that outlier. It'll be fine. If they were diabetic and high at home and high in the hospital, they'll still be high, and that can really help us figure it out if we're having trouble with these guys. So it's pretty simple to diagnose. I can do a blood test that day, I can send out a fructosamine, but there's a lot more to managing these cats than that. Diabetes doesn't occur in a vacuum. Most of my patients have other diseases, and it's those other diseases or other things that I need to manage that make this much more complicated. So my goal is to address the diabetes itself, and the 2 big pillars of that are diet, which needs to be a low carbohydrate, which has to do with the glycemic index, and insulin. Those are very important, but really, when I diagnose a cat, to me, that's the easy part. The hard part is looking for all the other things they might have that makes it hard to manage their diabetes. So obesity. I mean, if I diagnose a diabetic cat like this, boy, we need to work on that, because not only does he have a pancreatic deficiency, he's got all of this insulin resistance. And if I can get him skinnier, then we're in a good place. Chronic pancreatitis occurs in about 50% of cats that have diabetes. Pancreatitis, anytime you see an itis, is inflammation. So it's chronic inflammation of the pancreas. And when that happens, it's not secreting insulin the way it should be. And so that actually would be sort of a risk factor for developing type 1. Urinary tract infections are fairly common in these guys. Dental disease, and the reason we look for all these things that are inflamed or infected is if you have inflammation or infection anywhere in the body, it's going to cause insulin resistance and really affect your ability to manage them. So when I diagnose them, I need to be real careful how I phrase things and what I say to an owner, because when I tell them your cat is diabetic, some owners have very personal experiences with diabetes. They've either had it themselves, their sister died of it. You know, you don't know what you're getting into, so you need to be really tactful about it. Some people are just overwhelmed. Oh my God, my cat's diabetic. It's a death sentence. Other people have no idea what that means. They vaguely have heard of diabetes, but have no, medical training. And other people are really afraid of needles and insulin, and that's the first thing that pops into their mind, and they go, oh no, I will not give my cat shots. So I try to impart on them, this is a disease we can manage, but not cure. We will manage. And that your cat has to come back to me more often. And yes, it'll have more costs than a healthy cat, but I'm going to try and do my best to keep that reasonable and doable. But the other thing I usually tell them is that the #1 cause of death in diabetic cats is euthanasia. People feel that they can't do it. They're overwhelmed. They think their pet is suffering. And that's something that I think as veterinarians we need to try hard to manage and make this doable for folks so that it's something that they feel empowered that they can treat. If they're not euthanized initially, the average life expectancy after diagnosis is less than 2 years. And that's the average in the United States. My hope is to get these cats living their normal life expectancy or close to, even though they're diabetic. And we've got lots of patients that are 5, 6, 7 years post-diagnosis, which we're pretty proud of. Okay, so one of the big differences in treating people and cats with diabetes, yes, they both take insulin, but there's a lot of different types of insulin out there. People, and if anyone here is diabetic or has experiences and wants to correct me, I would not be offended. But my understanding is that people will often use short-acting insulins on top of sometimes long-acting insulins. And what that means is a long-acting insulin you might take once or twice a day. And so if you're a person, that would sort of be background control, just to keep things from being really too high. And then the short-acting insulin is only in your system a few hours. And that's where you say, oh, I'm going to eat a meal. I know it's going to spike up. Let me take my short-acting insulin and keep that under control. Dogs and cats, we can't ask people to be giving their cats shots, multiple times a day. So we usually use long-acting insulins that'll last 8 to 12 hours or more, and they give it twice a day. They've been trying to develop insulins you can use once a day, but it's just not really coming to fruition. So if that happens, I'll be excited. But so people, there's a lot of micromanaging, little adjustments if you're on insulin. Cats and dogs, what I want is consistency in the diet and consistency in the dose, and that's going to get me the best outcome. And what's fun is that my patients can have a consistent diet. They're not going out and getting fast food and making their own choices. If we find a kibble that they like to eat, they can keep eating that kibble. And that helps a lot with diabetic regulation. We used to joke in vet school, wouldn't it be nice if they had like vet student kibble, and then you wouldn't have to wait all this time, like going and cooking and stuff. You could just eat your little scoop of kibble. And then you could probably be better regulated on everything else too, but it has not caught on. Okay. I hope this doesn't gross anyone out. It grosses me out a little bit. That's why I work on animals. So complications of diabetes. I just want you to see the list in people is long. It's middle in the dogs, and it's shortest in the cats. So people, if you are a diabetic and you're not well regulated, you are going to have lots of potential problems. Heart disease and stroke, your risk increases at least 4%. High blood pressure, vascular disease where you don't get good perfusion, and then things like this happen because they don't have blood supply. Which leads to amputations. One of the biggest causes of amputations in the United States is diabetes. And one of my best friends is a physical therapist, and I'm astounded with how many people he works with that have had amputations because they're diabetic. Blindness, kidney disease, neuropathies. We're going to talk about DKA in the next few slides. You'll just see that that's common among them. dogs, the most common complication of, or the most predictable complication of diabetes is cataracts. So this is a dog that has cataracts. The lens becomes opaque. So it's kind of like mud on the windshield. You can't see through it. Their retinas still work. They might be able to see, except their lens is now all cloudy. And so this happens because of the way the sugar is metabolized in the lens. And it's very common in dogs. If you have a diabetic dog and he's 2 years after diagnosis, it's almost a guarantee that he'll have developed cataracts and gone blind. And so that's a real reason to try and control them as well as you can for as long as you can to kind of stall that from happening. If it does happen, there are ophthalmologists, veterinary ophthalmologists, who do surgery to remove the cataracts, and then they can see again. That's fairly expensive, though, and kind of cost prohibitive for a lot of folks. Sometimes what they'll do is instead of doing the cataracts in both eyes, they'll just do one. He doesn't have to read the paper or drive or whatever, but now he can see and fetch and wag at you when you come home. So those are things that really, this makes it so you have to have good control in dogs and people, because all these bad things will happen if you don't. They can also go into DKA, which I hate to give that acronym without explaining it, but we'll get there. Cats, the biggest thing they'll have is a diabetic neuropathy, which we're about to talk about, and DKA. But what I want you to notice is that these lists are so different. These dictate how tight the control needs to be. And where I'm going with this is we can have much looser control in cats because they don't get as many bad things if we don't have good control. So DKA is an acronym that stands for diabetic ketoacidosis. So you need to have 3 things to be a DKA. You need to be diabetic. You need to have toxic quantities or elevated quantities of ketones in your blood and your urine. And your blood pH should be acidic compared to normal. And all of this will lead to a very sick patient. Acidic blood pH really causes a lot of shifts in potassium and phosphorus in and out of the cells. And that will really affect their heart and their muscle. I mean, some of these animals look like they're on death's doorstep when they come in. They're comatose, they're not moving. It is really, really dire. What I find fascinating about this is every patient that has DKA has some second complicating problem. You can be diabetic and never diagnosed, but if you don't have anything else going on, you'll live with your high sugar. But anything else tips the scale. You have pancreatitis, a urinary tract infection, dental disease, infection or inflammation anywhere, then you can become DKA. So it's really important that we try to prevent this from happening. DKA, those patients have to be hospitalized. They can't go home. They need IV fluids. They need IV medications, intensive supportive care. It costs hundreds to thousands of dollars. And so it's really, I mean, for a lot of folks, that could be an endpoint. So we try to avoid this. What's really sad is sometimes the animal doesn't get diagnosed with diabetes. They haven't seen a vet in 5 years. They come in really sick. They look like this. Now they're a diabetic and DKA. So we have to say, we have to get them through the next 5 days here of DKA and see if we can get them back to being just a diabetic, and then you can manage them. So that's really sad. So if your dog or cat is drinking or peeing a lot, please see the vet. Okay. This is why DKA, we're so proactive about when we diagnose diabetes, we're looking for all those things because I don't want them to get this sick. And I also want it to be a lot easier to figure out what their insulin dose is without that factor of insulin resistance. When we diagnose them, we do a blood panel for pancreatitis. It's called a PLI. We collect a urine sample and we send it off for a culture and sensitivity looking for a urinary tract infection. We usually do a dental cleaning within the first month. Very rarely do I see an animal, oh my God, what nice teeth he has. They're gorgeous and just lovely breath. I mean, most of them have dental disease and that needs to be addressed. There's some controversy, and I understand why. You know, I was a microbiology major, about giving empirical antibiotics. We diagnose you with diabetes. Should we just give you a round of antibiotics to cover our bases in case you have infection or inflammation? That makes me a little bit uncomfortable because of my background in microbiology, but I've seen veterinarians do it. And maybe that's something that could save their life because you treated something without knowing it was there. But certainly something controversial. Okay. So now we talked about DKA as one bad thing that can happen to cats. The other one is diabetic neuropathies. Basically, this is almost like a toxicity from having too high a glucose. And when it's too high for a long period of time or you have poor regulation, they start to walk funny. And what will happen is they usually walk on their little paws, and then they start walking all the way on the flat part of their foot back to their sort of hock or tarsus. And it's called a plantigrade stance. That's how you and I walk. If you did comparative anatomy, that's how we walk, but cats are usually like walking around like this. And so it looks very abnormal. To fix it, you have to get better control of their diabetes. There's some theories about B vitamins and other things which I always give, and I'm not convinced if they help or not, but they're water soluble, so it's pretty safe. Once they develop this, it'll take weeks to months to improve. It doesn't seem to be painful, but it gives them a really weird gait, and they walk funny, and everyone that comes to their house says, what's wrong with your cat? And about 10% of diabetic cats, we think, develop this. So I've got some pictures. Here's a cat, and there's another cat with it. But videos are even better than that, so let's see if this runs. We'll give it just a second to think. Dr. Norsworthy, my boss, has about a picture and a video of everything, which is really useful when preparing a lecture, if it will go. Anyway, any questions so far while we wait on that? Oh, maybe it's going to be. Oh, that's Dr. Norsworthy behind the counter. He's squatted down with the cat. Okay, just a second. Here we go. Oh, maybe it's going. So you're going to get to see how this cat walks. It's a very short clip, so I'll probably play it twice. Or not. Ah, the picture's cool. Okay. See how weird he walks? That's from diabetes. And see how his foot is flat down here? They get calluses on the back of their foot where they normally have hair. They get calluses, just like our heel on the back there.
Because there's more weight on it, like at that point?
It's a neurologic weakness because of the toxic effects of diabetes. It's usually in the hind legs. I had one actually literally this morning, my appointment before I came over here. There was a newly diagnosed diabetic that had in the front feet, and he was walking real low on the front. I tried to get a video of that, but I couldn't get it uploaded in time. So anyway, it's very classic. That's a diabetic neuropathy and a reason to really try and get them well regulated. Now, so DKA and neuropathies are problems that develop because of the disease. What's scary is that when we treat these animals, they can become hypoglycemic or have low blood sugar, and that's because of the treatment, because of the insulin. So if a patient's blood sugar is too low, and 50 is sort of an arbitrary number, but less than 50 is certainly too low, that happens after an overdose of insulin. Now, an overdose of insulin is a relative term. I mean, insulin can be dangerous. So, you know, if you're not diabetic and you take insulin, it'll kill you because your glucose will go too low. But let's say you're a diabetic and you had all this insulin resistance, and we fixed it. We did a dental, we treated the UTI, we got rid of the pancreatitis. You still take your insulin. Now you don't need it anymore. You get a relative overdose because we're still dosing you. And so it's really scary. Hypoglycemia can be as mild as they're a little glassy-eyed and lethargic to their hypothermic, their body temperature is low, they're comatose, they can have seizures, and it can be fatal. And so this we really want to avoid. When I diagnose a cat with diabetes, I tell all owners, go to the grocery store and buy some Karo syrup. If your cat looks glassy-eyed or lethargic, rub this on his gums because he might be too unresponsive to swallow, but this is a syrup that'll just absorb across the gums, and that'll bring his sugar up. And if he's doing that for some other reason, it's not going to hurt him. So Karo syrup, they can rub it on the gums while they're taking him to the vet. So my goals when I treat a diabetic cat is control the clinical signs. I don't want them drinking and peeing excessively. I want good enough control of their blood sugar that that's okay. I want their weight to be stable. I want to avoid hypoglycemia. I mean, that is a huge reason that people will put their cats to sleep. They say, I just saw him suffer. That was miserable. We're never doing this again. We're done. And so I'm really pretty ginger with my insulin doses and real careful because I don't want that to happen because I know how scary it is for the cat and for the owner. And we want to address secondary diseases, all those insulin-resistant things. Let's get those under control. So the basic premise, this is in cats, not in people, is that blood glucose too high is always better than too low. And I can say that because elevated blood glucose is well tolerated in cats. They're not going to need amputations or all those crazy things. They're not going to go blind the way people and dogs are. They can tolerate it. And hypoglycemia is really scary. And when I worked emergency, once a week, I would see a cat come in hypoglycemic. And it really is absolutely sad. So the reality of veterinary medicine is I have to do all of those things. But I also have to keep the cost reasonable. I have to keep the recheck intervals reasonable. And I can't ask the owners to do too much at home, because if they have an angry cat or a grumpy cat, they're also going to quit. And so we really need to work not just on the medicine, but on the people and the cats and make sure that everyone can do this. So what I want is the happy owner and the happy cat and everyone feeling good at home. And so that's why it's so different than being a human doctor. So this leads to, I treat insulin very differently in cats than you would in people. Strategies for management of diabetes in people, they have tight control. So the glucose needs to be really in this narrow margin. You're checking your blood sugar all the time, and it's very labor intensive. I do not ask dog and cat owners to do that. There's some veterinarians that will try to do tight control, but I think those are the ones that probably live less than 2 years and people get fed up. Loose control, I've done this with several dog patients that I had when I used to work with dogs, and in some cats, where you say, okay, the glucose can be a little bit higher, we're not going to check it as often, or we'll do something called a glucose curve, and we won't get into those details, but it's moderately intensive. Or ultra loose control, which is what we do in cats. I would not do this in a dog, I would not do this in a person, but what we're going to look at is clinical signs. How are they doing? Are they drinking and peeing a lot? Are they eating a lot? What's their weight? More than the blood glucose. I'll accept a blood glucose up to 400, as long as the signs are controlled, because a lot of times when I see them at 400, they're stressed out. So that doesn't get me too concerned. And what I'll do is when I diagnose them, we'll check their blood glucose once a week, and it might start at 600, and then 500, and it would be beautiful if it went 600, 500, 400. It never does that, but what I want is it to slowly come down as I slowly increase my insulin dose. Once I have them regulated, where their glucose is 300 when they come in, they're doing great at home, then I say, great, let's see you in 6 weeks, and just keep doing the same things at home unless you have any concerns. So the ultra-loose in cats, you start on a very low dose of insulin. Again, we don't ever want to overdose on insulin, and we very gradually increase. We recheck once a week, and really, I try to impart this to the owners, that I really care about what their body weight is. So when cats come into us, we put them on the scale and we weigh them. Here's an 11-pound cat. And then at each subsequent visit, we keep weighing them. And our computer system can make a chart. And I can make the chart, and we've got a computer, and I show them. I say, oh, little bit's weight really dropped off. And this is when we diagnosed him with diabetes. We started treating him, and he started getting better. And so we watch this. And if they're losing weight, that's a red flag that they're in trouble, unless they're on a voluntary diet, in which that might be good for their insulin resistance. But if I like their body weight, I don't want them losing, because that means that diabetes is getting the best of them. I ask about how much they're drinking and peeing, how energetic they are, their hair coat and grooming. They don't have to do any blood glucose checks at home. The owners just give the insulin and watch their cat, which is about as much as you can ask. Okay, so to me, regulation is, this is the grumpy cat, now happy. He says, I love everyone. Okay, I want clinical signs resolved. The cat is happy and interactive in the home. The body weight is stable. The owner is satisfied with the progress, and if possible, I don't even get as picky about this, if possible, the blood glucose between 100 and 300 throughout the day. So there's another approach where you ask owners to get a blood sample from their cat and prick their ear and check on a glucometer. We don't use this in the Ultraloose because I don't care, I'll see you in a week, and I'm starting really low and conservative. But the theory is that having the owners check at home eliminates that stress factor of getting in the car and coming to the vet. I put a question mark there because I question if that eliminates the stress factor. If you have to hold your cat and prick its ear. Now, I've done this, and I've pricked my own cat's ear. It's not too bad. They make little lancets, and there's a vein that goes around the outside of the ear, in a little U there. And it's about 1 millimeter or 2 off the edge of the ear. So if you shine a light through a cat's ear, you can see it, and you just prick where it is, or you use a lancet. And I think that's actually probably okay. But the trouble is, then human nature is the owner does that, and they hold their glucometer, and they see the number. And the first month or so, they call me, and what does the number mean? What are we going to do when we talk about it? Well, human nature is, after a while, they stop calling me, and they just start regulating, and they just start adjusting the insulin dose. And that really scares me, because they haven't had medical training, and there's a bunch of other factors that they don't know about. Insulin can have a cumulative effect, so if you change the dose today, you probably want to wait a week until you check and see the real effects of it. You won't know it tomorrow. And so there's a few other things where the glucose levels can go really high and really low and kind of oscillate, and that's called somogy. It's very dangerous, and owners don't understand that, and so I don't give them glucometers because they get number crazy and they stop looking at the cat, and I don't want them to do that. Okay, now what about diet? Cats are obligate carnivores. People and dogs are omnivores, unless you choose to do differently, which is okay. But cats are obligate carnivores. They have very different dietary needs than us. They need a low carbohydrate diet and a high protein diet regardless. But if they're diabetic, they really need that. We call an ultra low carbohydrate diet less than 10% carbohydrates on a dry matter basis. you can only achieve that in a canned food because you need a certain amount of carbohydrate to pack together to make a kibble. So the dry foods that are diabetic foods are maybe 11 to 15% carbs. But they need to be high protein, and most of those are greater than 50% protein. Cat food was originally made as a marketing offshoot from dog food. People had dogs. Here's your Purina dog food. Oh, they have cats now around the house too, and they want to buy cat food. Let's just make the kibble smaller, I think is how it started. But basically, the first commercial cat foods, and even some of the ones on the market today, have way too much carbohydrate and too little protein, and they're just smaller kibbles. And that doesn't fit because cats are completely different as a carnivore. And so we joke and call it the catkins diet. They really need much higher protein, and that is appropriate for a cat. They are like little lions that live in your house. Okay, again, we have to make this work. I tell the owner, okay, your cat's diabetic. Now you're going to feed this food. And she goes, oh, no, I'm not. My cat only eats Fancy Feast. And I swear, Fancy Feast is addictive for cats. It's like cocaine is in there, and once they eat that, they will eat nothing else. So we have to make it work. If they won't eat the diabetic food, what we did, we sat down and we went through all the flavors of Fancy Feast. And I tell you, there have got to be hundreds of them. But we made a list of all these ones that are the accepted flavors. And what they are, you can't read it up there, I'm sure, but high in protein and low in carbohydrate. So that is the diabetic-friendly Fancy Feast. And it's not as bad as the other flavors. And we say that's okay. If your diabetic cat won't eat my prescription diabetic food, he can eat that, and we'll call it good. Okay, so take-home points. Diabetes in cats is most like type 1, but they have all those factors of type 2. I try to make it so it's just type 1. They have factors that contribute to insulin resistance. It is fatal if it's not treated. And I think if it's treated incorrectly, or you ask too much of them, or something goes bad, then it's fatal by euthanasia, which is equally sad. So successful management in cats, we can do Ultraloose because they don't get those severe diabetic complications that people do, thank goodness. And then the other thing that I really try and impart to owners is knowledge is power. I want the owners to be inspired and involved. I don't want them to be scared or intimidated. You know, I've taught grandmas how to give insulin injections, you know, but they can do it. And that's really cool. I think that's awesome, you know, because some of those people, that cat's what they have. And so I think it's really neat to sort of be a part of that bond. Okay, now this is just really fun at the end. This was an x-ray. This cat came in. The guy said, my cat's been vomiting for 2 days. I don't know what's wrong with him. And I examined him, and he flinched every time I touched his throat. I thought, wow, that's really weird. Normally a vomiting cat, I'd take a picture of his stomach and, you know, see if he ate something there. I thought, you know what, while I'm here, I'll just take an x-ray up front. And so this is an x-ray with the cat's head facing this way, and then down his neck, and that's abnormal. And then this is his head looking sort of straight on. That is a sewing needle. Very exciting. Now, this picture doesn't show it very well, but because of the bone is in the way. But his soft palate, the roof of his mouth, will come down here and here. And in the next picture, I couldn't see it when the cat was awake because it's hard to open an awake cat's mouth very well. But once I sedated him, opened his mouth, this is his tongue and his open mouth. That's his soft palate. There's the needle with thread wrapped around it, poking through. And the string is going down his throat. So what did we get to do? We grabbed it, and we pulled on it, and then we got out of the needle. What I was afraid was if this is really long, it could have gone into the stomach and been anchored there, and then I would have had to cut the string, take what I could out at the top, and then do surgery in the stomach, but we didn't have to, so that was good. That was very exciting the other day. So anyway, so that's why veterinary medicine's fun, is you can talk about diabetes all morning and then do cool things like that, and I just love it. So if you have questions, we can chat. I'm sorry if that was a little long. It's good. Okay. Oh, and these are all books I love. I told you about James Herriot. These are other excellent books if you ever get a chance to read. This one I think people think is corny, but it's not. How to Win Friends and Influence People. It's amazing. It's really outdated. It was written in the 30s. They talk about like bosses and secretaries and stuff. So take that with a grain of salt. But it's very, very good, How to Win Friends and Influence People. This one, if you love science and problem solving, Microbe Hunters is about like Koch and Pasteur and the first guys that started to work out this. It's fascinating. How Doctors Think, this is sort of scary. It's written by a guy who works and teaches at Harvard, and he talks about all the ways that doctors get into trouble in thought processes. And so it's sort of like psychology and medicine, and we like things to fit in a neat little box. This comes in, this is your problem, this is your diagnosis, this is your treatment. But the real world really isn't that way. It's much more complicated. But if you get diagnosed with something and then you get a second opinion, your records get faxed over, that doctor is already biased by what he heard. It's very tough if you're initially misdiagnosed to correctly get diagnosed. And they tell these horror stories that will scare you. So be your own advocate if you go to the doctor and read this book. It'll really scare you. And then Outliers is excellent. As the name implies, It's about people at the end of the spectrum, people that are outliers and exceptional in their field. How did they get to be so good in that particular niche? And they talk about plane crashes and airline pilots and what went right and what went wrong. And it's just, you'll be on the edge of your seat the whole time. So if you don't have enough work to do right now, or you're going somewhere for spring break and you need to read, those are all excellent. So I'm a big nerd and I like to read, and if you do too, you can. Okay, questions? Anyone?
Dr. Squires.
Yes.
Maybe a comment, in type 2 diabetes in humans, or the adult onset diabetes, we used to call it.
Yes.
Now we say it in children as young as, well, we've seen type 2 diabetes in children as young as 2 and 3 years old.
So scary.
It's preceded by a syndrome called metabolic syndrome. Metabolic syndrome is not quite diabetes, but blood pressure is elevated 130/90. There's 2 standard deviations above the BMIs. They have a hyperlipidemic, high cholesterol. So then they go into the type 2 diabetes very, very young. It's a pandemic in kids. So the age 40 is.
Yeah, that might be a bit outdated. I agree. And I mean, it's scary. I mean, I don't know if you guys watch Biggest Loser, but they just did their season right now with, childhood diabetes, and it's such an epidemic, and it really is sad. But I think it's something that's manageable, and if people can learn and understand, it's not a death sentence. And
the second thing, the carbohydrates that are fed. I did a review of a pet food store. One of my sons and I were interested in what we're feeding our animals. So much of the carbohydrate that's in pet food, we were specifically looking at dogs, is high fructose corn syrup. And if you know high fructose corn syrup,
that kills me.
there's a slide on the receptor where you get in with the GLUT4 receptor, glucose. Well, fructose doesn't have one of those. Never has, because we stored it immediately as triglyceride and through the liver as fat. So that was the obesity. So when you're picking an animal food, you have to be very careful that the carbohydrate is not corn syrup. Corn syrup and high fructose say the same thing. The second thing is the protein that they're using in animal feed is not a true animal protein. It's a soy protein, and 95% of it is genetically modified soy. So we don't know what's happening to genetically modified soy in humans, let alone animals, but we think there's a lot of ascites and stomach distress because of that.
Oh, I wonder.
Is you can buy
So
this,
scary.
you can buy that.
Yeah.
Those are just kind of-
Well, and the pet food labels, terrible. There is nothing useful on a pet food label because what they give you is crude protein percentages, not digestible protein. So the ultimate example is chicken feathers. 90-some% protein, 0% digestible. So if you want to make a cheap food but have lots of protein and put a picture of a wolf on the front, then you put in chicken feathers and you have high protein levels, and consumers can't tell the difference, and it's absolutely terrible. There's a regulatory body called AFCO that dictates what is put on pet food labels, and if I had enough time to get into politics, I would do that and try and make them put different things on there, because it really is so difficult, even if you're educated and knowledgeable, to know what you're buying, and that's scary. It really is. So anyway, anybody? Stunned to silence. Any other stories that are cool? Oh my God. I should write books like James Herriot. I mean, every day is really fun and interesting. I mean, some of them are sad. It really is emotional to be a veterinarian. And what's tough is sometimes you can't even indulge in the emotion. You sort of have to be there for the people, because I'll have days where you go from a euthanasia to a new puppy or a new kitten, and so you have to just almost be an actor, just flip the switch. And I feel like sometimes I have to go home and process it. And so having very patient people around you that will listen to your stories again when you get home, because now you need to deal with it, is good. But in my internship at Alameda East, I was on overnights, and an African tortoise came in, and I thought, oh gosh, I must have slept through that class. No, wait, I didn't have a class on African tortoises. And it came in, and in Colorado in the winter, and they said, he has this little heated thing, and it's in the yard, and he always goes back into it at night, but he must have just decided to sleep outside tonight, and we think he has hypothermia. Actually, we think he's dead. Is he alive? And he's this big. And I go, let me take him to the back. And so we go to the back, because I don't know what to do. And he's cold to the touch, and he's in his shell. I honestly didn't know how to tell if the turtle was alive. So I was like, oh boy. So I was like, well, I could Google it. So I do that. And I found out that they'll have a very slow resting pulse anyway, and that you can use an ultrasound to probe and visualize their carotid. But you have to be very patient, especially if they're hypothermic. It'll be even slower. So I stood there for 3 minutes with the probe. I was like, God, I think I'm over the right place. And we watched, and finally he had a pulse. Okay, he's alive. So now we got to keep him alive. And so then I called Dr. Fitzgerald and said, all right, I've got this turtle, and I know he's alive. I ultrasounded the carotid. And he said, oh, good work. Yes, thank you. And yes, I'm going to be a turtle expert any day now. And so he's like, all right, well, what you can do, you got to put him in the incubator. I was like, yes, of course, the incubator, yes. So we put him in the incubator. He's like, but you can put warm fluids into the coelomic cavity, which is like their abdominal cavity. And I was like, all right, so like, how much, or like what size needle, or like where should I do? So it's like by the leg, and you get a long needle, like you were going to do a spinal tap on a big dog. So we did that. We put him in there. But the worst part of it is, when you're the overnight doctor, morning rounds happens in the morning, and all the specialists are there, and they want to know how their little seizure patient did overnight, and their post-op knee surgery, and blah, blah. So you have to do a formal presentation in front of everybody in the ICU. And there's a very specific format that you present your case in. So you'll say, this is a 4-year-old German Shepherd who presented with blah, 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 blah. And my diagnostics were this, and pertinent findings were this, and this is my treatment plan, case closed. And then they grill you. And so it gets to me, and I have to talk about the turtle, because we go around the room like cage to cage to cage, and I know we're getting closer to the incubator, and I'm like, oh my God, I don't want to have to present this. And so I get up there and I start presenting. I'm like, okay, well, this is a, we think, 28-year-old African tortoise and a turtle, and like I'm like stumbling over all of that. And so then I'm presenting like physical exam findings were cold to the touch, could not extend limbs. Like I'm really trying to make it sound better than it was. And one of our surgeons was just dying. He was like stifling laughter in the corner, trying to be professional. And so everyone laughs at me and teases me about turtles all the time because of my rough overnight. But he lived and he did really well. And then they sent, that was like in October, November, and they sent me a Christmas card with a turtle on it, and he had a little hat on. And so it's fun. There's like both sides to it. And so I kind of miss the excitement and pace of overnights. Yeah.
Did you find out how the sewing needle got in the cat's neck?
Oh yeah, so this is a good story. Yes, so cats like to play with string. You were waiting for it, I know. So cats like to play with string, and string is often attached to the needles. But the best part is I call the owner, because I wasn't expecting to find this. I thought, oh, this is just a whim. So I call him and I say, you're not going to believe what I found. There's a sewing needle in your cat's pharynx. What I need to do is sedate him so I can get it out. And he said, but I don't sew. I said, well, it's definitely a sewing needle. I don't know. You definitely have a sewing needle in there. And so we take it out, and I call him back later. Everything went fine. She's doing great. Yep, she's able to eat now. She feels a lot better. And so he must have thought about it overnight, because he comes the next day to pick his cat up, and he says, you know, I did. I put a button back on my pants the other day. I didn't think of myself as a sewer, and so I wasn't thinking about it. And he's like, yeah, that must have been it. And I was like, oh my God. So yeah, it's crazy. So it's so much fun. I just love my job. I feel like it's like a hobby I get paid to do. You know, it's definitely good with bad, and there is paperwork and stuff, but it's completely worth it. So yeah.
Is there a correlation between an obese cat and an obese owner?
Yeah, actually, this is the topic. I went to a lecture at a veterinary conference, like a continuing education conference, about veterinarians that find it awkward to bring up to an owner that their pet is fat if the owner is fat. Exactly. And I thought, wow, I must be really insensitive. I never thought about that. I just deal with the pet. We should do this. And I don't think of it as a, but ever since going to that, I've thought about it in those ways. And it is. It's a little tough. And a lot of times folks will be like, well, that'd be good for me too, but not in our house. And you know, it's really awkward. Like, what are you supposed to do? And so I think I just try to make it, my focus is to take care of your cat. And I'll make the best recommendations for your cat. And guess what? We have some options. He might like Fancy Feast. We have a few different things. I don't want you to feel like he's deprived. And that's what I think people imagine, is that, oh, to do this, he's going to be a sad little cat, and he's going to be deprived and unhappy, and all the things that are preconceived about diets, which hopefully I can change their mind by saying, please just try a few cans. And lots of times, fortunately, the food companies have gotten better. Some of the diabetic foods they seem to really like, and they call me back and say, boy, I didn't believe you. I just took that to humor you, but he did eat it, so I guess we'll buy a few more, but not a case. I'm like, okay, just a few more. Don't buy a case, you're right. He might not like it next week, but yeah, I think it really is tough. And I don't know, I try to keep my focus on the pet because that's really what I'm there to do. Have you had that experience?
Yeah, I just
Yeah.
recently did a weight
It's
loss.
really
study,
awkward.
a new diet that came out, the science diet has, and it's fabulous. And, you know, this woman brought in this cat, and he weighed, I don't know, he was over 30 pounds.
Oh my God.
And she was very, very overweight. And I suggested it to her, and I mean, you know, I just presented it to her, and I never even made the link with the client.
I know,
I ended up
sometimes I don't.
losing a patient and a client because she, you know,
So
my
offended.
cat is not overweight, you know, he's healthy. And I mean, you know,
Yeah.
I think that, you know, we do that as humans too.
That's true.
You know, we internalize and we sort of think that, I mean, and after that, I mean, I was very cautious in the clients that I was presenting it to because,
Yeah.
you know, and I was shocked. I was
Yeah.
just shocked.
Well, and it's like parents with children, you know?
Yes.
They had a survey on Biggest Loser, and a ridiculously high percentage, I think it was like 75% of parents with overweight or obese children don't think they are. They think they're in a healthy weight category. And whether that's denial or true, just not seeing it, I think it's the same with the pets. Well, I love him. Look at how much I love him. I cook for him and I make all this stuff and I go, okay. So, and I do think it's really tough, but I will keep saying things. That's me. I'll say something gently, but say things. So, okay, you have another class to go to, I'm sure.
Students at TLU engage in high-impact educational experiences that include civic engagement, aesthetic expression, critical thinking, and a focus on intercultural knowledge in a community that welcomes the interplay of faith and reason.